and come back in. Okay, that was perfect. And now I'm going to be palpating for what we call tactile fremitus.
Okay.
The key here is that you use a bony surface of your hand, either the side or the bones right here in this part of your hand. I find it easier to use the side of my hand. And what I'm going to have you do is say 99.
99.
Good. 99.
99.
Okay, and you do that in the same areas that you listen to, and the key here is that the vibrations should be stronger over the bigger airways and get less as you move down. If it is increased anywhere where it shouldn't be increased, then you're going to be suspicious of something like consolidation or pneumonia might produce that kind of thing. So that's tactile fremitus. Then I'm going to do some percussion. Percussion is sometimes a challenging skill, and it takes a lot of practice, so there's some key things to it. First of all, you want to almost hyperextend your finger at the distal joint and place it firmly on the skin. So in this case, I'm going to be on your back, and all my other fingers are not on your skin, and just the one is touching. And then I take my hand, my finger, I'll show you, and I'm going to just move at the wrist, not at the elbow, to percuss. So. And you try to, I usually try to make 2 or 3 taps, and I want to be able to hear a really clear sound. And what we're looking for in the over the lung fields is called resonance, which is a little different than some of the other sounds. But if it's over a dull area, it's much different. So that's the key. Again, side to side in some of the same areas that you listen to also. That's percussion. One of the things you do is also, that's a special technique, is if I were to do your lung exam and I heard an abnormal sound, a wheeze or a crackle or bronchi anywhere, the next thing that I would do is ask you to cough and clear. So I'll do that right now. We're going to pretend that I heard something down your right base. Can you take a big breath and cough for me? Good. All right. And now I'm going to listen one more time. Big breath. Good, and go ahead and blow it. Okay, great. The next thing is also something we listen for, and these are some special tests that, so we see if your voice sound is transmitted through the tissue like it should be, or if it changes because something else is in there. So for example, if you had a consolidation from a pneumonia, the way that voice transmits at that point is, it changes, and what we hear changes. So there's 3 tests. Typically, you don't need to use all 3 of them at the same time on the same patient. Mm-hmm. Sometimes one is just very clear, and then you can guess what's going on. If one is kind of equivocal, you may choose to do the second test, and it doesn't really matter which one you use. And the way you use them is that you want to do it comparatively. So again, assuming that I'm hearing something in the right base of your lung, what I would do is each of these tests comparing that area from what I hear to the next area above it and beside it. So we'll do that now. If I could get you to say the letters E.
E.
Okay, good. And now E.
E.
Good. I'll come up a little higher. E.
E.
All right. E.
E.
Good. All right. And that one, I can hear it very clearly. It sounds like an E. An abnormal would be if it came out as a flatter sound, something like an ah. Mm-hmm. One clue I've learned in terms of listening to that is oftentimes if you're actually hearing it, you may suspect your patient isn't saying E because it sounds so different when it actually is like that. So oftentimes what I'll do is take one ear out of one stethoscope piece out of one ear, and then I can hear what you're saying at the same time I can hear what it sounds like to tell the difference. So the next one that's like that is whispered pectoriloquy. This one I'm going to have you just whisper 1, 2, 3. 1, 2, 3. Good. 1, 2, 3. Okay, and again you compare side to side and up and down and try to see the boundaries. If you're hearing an abnormal sound, you want to know where it changes to normal to get some sense of where the abnormal tissue is. that one, you would expect that again to be louder up at the bigger airways and get much softer and quieter as you go down. So if it's much louder in a place you don't expect it to be, that's an abnormal. And the last one would be what we call bronchophony, which is where I have you say the word 99 and again listen in all those areas. Very similarly to the last one, it should be louder over the larger airways and get softer as it goes down and farther away from those. And so if it gets louder as I go down, then I'm suspicious of an abnormality there. Usually those kind of changes sound like are due to a consolidation. The other thing that can sometimes cause that is if you have a pleural effusion in the which is fluid below the lung tissue, and then the lung tissue compresses, which actually makes it almost sound like consolidation. So you can get those noises at the top of a pleural effusion too. All right. Now we're going to come back to your front chest. The only thing would be to think about in terms of the exam is if anyone is complaining of pain with coughing or chest pain of any kind, that part of your exam is always that you palpate the chest wall and see if you can elicit a pain, because typically a pain that you can elicit is not going to be of cardiac origin, and that helps you with your differential in terms of what's going on. All right, and that's it. All right, Jillian, we're going to do a few more tests on you based on some findings in the last exam that we might use if we found abnormalities in the neurological system. And so thinking through the cranial nerves, if I were to find that you had difficulty in hearing cranial nerve 8, I would go ahead and do the Weber and Renee test. And I would, which we've already learned how to do in the HENT exam, but I would use the high-pitched tuning fork to do your testing. And the other thing we can do, let's see, I'm going to have you scoot back again a little bit and just dangle your feet for me and see if I can do it this way. And so I'm going to just sit down here and I'm going to kind of move your foot around for just a minute. Okay, and that is looking for ankle clonus, and you don't have any, so that's good. One other test I can do in terms of looking at your neurological function is I'm going to take your hand and I'm going to have you close your eyes for a minute, and I'm going to move your thumb around.
Okay.
And when I stop, if you can tell me if you're up or down.
Up. Down.
Okay, we'll try that on the other side.
Up. Down.
Okay, and we can do it. I'm going to go down and do that on your feet. Also, I'm just going to bring your foot up here for just a second. So go ahead and close your eyes. And I'm going to hold on to your toe.
Up. Down.
Okay, perfect. So that tests something similar to the vibratory sensation that we did. And now what I'm going to do is a few special tests that help me understand how well your brain is interpreting data that's coming to it from the sensor nerves. So the very first thing is I'm going to have you close your eyes just like you did. And I'm going to turn your hand up for a second. I'm going to put something in your hand without opening your eyes. Go ahead, you can feel it. Can you tell me what that might be?
Feels like a coin.
All right. Any guesses to what kind of a coin?
Maybe a penny.
All right. Now I'm going to have you give me the other palm. I'll put something different there. Can you tell me what that is?
That's a paper clip.
All right, perfect. So that was sterignosis, which you did fine. You were able to identify those things. And now I'm going to take your hand again, and this time I'm going to write a number. Can you tell me what it is?
3.
Perfect, okay. And now I'm going to write a letter.
A.
Okay, perfect, okay. And one more time. I'm going to be touching you with, you can open your eyes. I'm going to be using your hand again. I'm going to be touching you with a paper clip here. It's going to feel kind of like that. And I want you to tell me if it feels like I'm touching you with 1 point or 2 points.
Okay.
All right, now you can go ahead and close your eyes.
2. 2. 2. 2.
Good. Okay, you can tell it all the way in. And an abnormal would be if after I get closer than 2 millimeters, or a little bit broader than 2 millimeters, if you are unable to tell if it's 2 or 1. But you could tell. I couldn't get any closer than that. All right, now I'm going to have you close your eyes one more time, and I'm going to touch you. And if you could tell me where it is I'm touching you.
Arm. Arm.
And what part of your arm?
Forearm.
Okay.
Arm. Forearm. Hand. Leg. Leg.
Okay, good. In this next test, I'm going to touch you again, and you're going to feel my hand on you, and if you could tell me if you feel me touching you in 2 places or in 1 place.
Okay.
All right?
2. 2. 2.
Okay, good. And you recognized correctly that was 2 places in every single one. So I'm going to test your strength in these special techniques. If I could have you hold your hand out like this, don't let me push your fingers in.
Okay.
Okay, good. All right. And now I'm going to test your thumb strength. If you can turn your palm over a bit. Take your thumb and try to touch your little finger, and I'm going to resist you. Perfect. Okay. Do the same thing here. Try to touch your thumb to your little finger. Good. Okay. Now I'm going to have you do is put your wrist up like that, and don't let me push it down. Good. Okay, let's do that with this one. Put your wrist up, and don't let me push it down. Perfect. Okay. Now we're going to test the strength more explicitly in your lower extremities, even though we tested you going across the room. And so what I'm going to have you do is kind of just put your hands over there. I'm going to have you try to bring your knee up against my hand, and I'm going to resist you. Good. Okay. Let's do it on this side. Good. Now can you push your knees out against my hands? Push me away. Good. All right. I'm going to just tuck that up there and bring my hands on your knees. Try to push me in. Good. All right. I'm going to put my hand under here, and can you push down as hard as you can? Good. All right. Whoops, I'm sorry. Push down as hard as you can. Good. All right. Come down here to your lower legs. I'd like you to push out as if you're going to kick me,
Okay.
and I'm going to resist you. Go ahead and kick. Good. Now this leg, kick. Good. Now try to pull your heel back up under the table. Good. Heel back up under the table. Good. All right. Can you bring your toes up towards your nose? Good. And step on my hands like you're stepping on the gas. Perfect. All right. Last one, I'm going to check your big toe here. Can you bring your big toe up against my finger? All right. And this against my finger. Perfect. Okay, thank you. Your strength is all 5 out of 5. Super. Now, what I'm going to do is grab this blanket here, and I'm going to have you go ahead and lie back down. And I'll give you a footrest. I'm going to cover you up here for just a minute. All right, I'm going to lift your gown up so that I can take a look at your stomach for just a minute. And keep you covered. All right. Perfect. Are you okay?
Yep.
All right. I'm going to try this. May tickle a little bit. Good. Sorry. All right, now, if I were suspecting for some reason that you had meningitis or some inflammation of the meninges in your brain, like a high fever, a terrible headache, bright lights hurt your eyes, I would do some tests to check for to rule out meningitis or potentially rule it in. So the first thing I'm going to do is just have you go ahead and relax, and I'm going to just try to lift your head up for you. All right, so then I'm just checking to see how flexible your neck is or if you're fairly rigid. The next one, what I'm going to do is I'm going to lift your neck up. There you go. And I'm watching to see if you flex your knees in response, but you didn't. So I think you don't have meningeal problems, which is good. And I'm going to cover you up. I'm going to just lift this knee up for a minute. I'm going to bend it at the hip. And then I'm going to go ahead and straighten out. You let me know if anything hurts. Is that okay?
Yep.
All right. Good. All right, now what I'm going to do is test the sensation on your feet.
Okay.
I'll just do your right foot down here and uncover you. And what you're going to do is, I should show you what this is like. So that's what kind of what it's going to feel like.
Okay.
All right, and when you feel that sensation on your feet, just tell me now, okay? Go ahead and relax your feet. There we go. Okay. Good. All right, and I would do the same thing on the other foot. There were a couple spots that you didn't have quite as good a sensation, but I also think I'm working over the areas of your feet that get a lot more wear and tear. And sometimes the skin is thicker and doesn't, you lose some of that sensitivity. So that was normal. So that's the end of the exam. Thank you very much, Jillian, for being my patient for the 501 Special Techniques demo. And I'm going to go back over some of the techniques that we did in the demo and bring out some key points to remember as you're either doing the exam or interpreting the exam. So I'm going to refer to my skill guide. The only cranial nerve we really looked at in the special techniques was the acoustic, and the thing to remember with that is typically the better tuning fork to use for the Weber and Renee is the 512 versus the lower number, only because this is a better equivalent to what the human speech is, and that's really what you're trying to test for, is someone's ability to hear human speech, because that's the functional goal that we have for hearing. And deep tendon reflexes would be done typically if you suspect some hyperreflexia, or if you discover hyperreflexia during your exam. It is often used in OB settings if you find hyperreflexia it's one of the tests you do when you're worried about hypermagnesemia. I think I'm not an OB nurse, but I believe that's it. The joint position testing that we did, I'm going to take your hand and, why don't I pop this out of the way again. So the key points to doing this is that you have your patient's eyes closed, so they don't know what it is that whether you're up or down. And then you hold the sides of the joint versus the top and bottom, because that eliminates a little bit pressure, which may tell the person if it's up or down, and you're trying to eliminate anything that will help that. And this is another test very similar to the vibratory sensation test. It travels up the same pathway to the brain, but it's another test you may be able to use if you want to. And the monofilament test we explained is something you might use with, especially with diabetics. That's the population that has been tested in, and it's considered more sensitive than light touch or pain sensation testing. Studies show that maybe it's equivalent to the vibratory. It's hard to say which one is more sensitive, but either one would be good to have for your diabetic patient. And primarily you're looking for, with the monofilament testing, it may help you predict increased risk of ulceration and then therefore not poor healing. It's important to remember with the special test that I did, one of which was stereognosis. So stereognosis is the one you would do first kind of as a screening test. And if that was abnormal, then it was hard to tell if it was abnormal, then you'd move on and do some of the others. So the very first one, stereognosis, was I'm going to have you close your eyes. Now you already know the answer, but I'm going to put something in your palm, and you can let your patient go ahead. You can go ahead and feel that, and then tell me what it is.
A penny.
Okay. And we fooled you. You made it a
it's a
dime. Yep. But so that's the very first one. Graphesthesia, I think one tip to doing that one is some patients are really good if you write a number. Go ahead and close your eyes. Tell me what this number is. That's a little harder, isn't it? So, okay, let's try that again.
4.
4. So if you'll think, I would say write your letter or your number the same direction that the person would read it that's getting the sensation, because that's a lot easier. Some people can very easily flip them around in their head, and other people have trouble with that, and that's not a bad thing. The 2-point discrimination, the key to this is an important test to do correctly. Every time you're touching them, you're touching with 2 points of a paper clip at the same time, but you're getting closer and closer. And you're trying to determine when it is that they can no longer distinguish that it's 2 points and it feels like 1 point. And the normal for this on the fingertips is about 2 millimeters. If at 2 millimeters they're still telling that something is 2 points versus 1, that's normal. That's different in other parts of the body. So if I could get you one more time to close your close your eyes. And I'm going to touch you again, and you tell me if you feel 2 or 1.
2. 2. 1.
There you go. So a little bit, she's actually still got pretty good sensation in terms of the 2-point discrimination in her upper arm, but not as good as on her fingertips. And if you think about this, it makes sense if you think of the homunculus picture of the brain and all the little parts of the body. The hand is huge on the homunculus, and so it has lots of sensory input, lots of sensory innervation, whereas the arm is less, and then for other parts of the body are even less. So in terms of testing with this, you could do each side of the body, but you are always testing with 2 points. You're not testing with 1, and you're trying to see when it is they no longer recognize it as 2 points. For the purposes of the demonstration, you can do that on one side and just demonstrate how to do that technique. These tests are really it's important to know that if you don't have intact sensation, you can't really do the test accurately. And mostly this is trying to figure out if the brain is interpreting sensation correctly versus actually testing sensation. The point localization, when you have them close their eyes, go ahead and close your eyes, and then tell me where I'm touching you.
Forearm.
Okay, good. So you touch different parts. You do each side of the body, you touch different parts. If this were someone who was nonverbal, like a patient that had a stroke, they can also point to the area that you've touched, and that also will help you know if they're localizing correctly. And then the very last one we did was extinction. And it's important for this test. I'm going to have you close your eyes again. I'm going to touch you. You tell me if you feel me touching you in 2 places or 1, okay?
2.
Okay. The key point in terms of the person doing this exam is to touch them in the same places on the opposite sides of the body. And if their brain is taking in stimuli better on one side than the other because of damage, such as a stroke or an infection or a bleed, even when they're just getting one sensation, they can tell you accurately they feel it. When you are touching both sides of the body and one side of the brain is working better, then it extinguishes the sensation that comes in from the other half of the body. So that can be a clue that something that's fairly subtle is going on in the brain, but that it's not a normal. Strength testing in terms of the key points. Let's see, with finger abduction, which we did. The idea here is go ahead and hold your fingers out. You're just doing the outsides of the fingers, not each little individual finger, and giving fairly good. But you're going to notice that you are stronger than your patient because those are not strong muscles. Our muscles are going to be stronger than theirs, and that's a normal. So again, you're comparing the patient side to side, which is what you're always doing, to try to figure out if it's normal or not. When you're doing strength testing, it's very important to put yourself in the position so that you can give full resistance and really test their strength. Depending on what's going on. If someone was an athlete and you're assessing them to see if their strength is back to where it needs to be and they need to go out and it's suppose it's a 200-pound football player that's sitting here instead of this not 200-pound person, you need to have good body mechanics to get your full strength because their muscles are going to overpower yours fairly significantly. So if I'm doing lower extremity testing, I'm going to have you put your hands here. And so we wanted to do hip flexion. Go ahead and come up against my body. So I really get myself in a position where I have full power going down as opposed to standing back here. That I don't have a lot of power in that position. So I put myself right here. Do the same thing on this one. Good. Okay. I get my hands around for coming out. I'm going to go ahead and bring this towel in here for a minute. Okay, go ahead and come out. Perfect. Now, what I do when I do the adduction, which is coming in, is I cross my hands. Because if I try to do it like this, that's a very weak position in terms of my muscles. So instead I cross my hands, and I'm a little stronger. Go ahead and push in, although she's a little bit stronger than me, and I can't correct for that. Again, for the legs, I tend to get down and get right in front of the leg with my arm lined up, and I'll go ahead and push out as if you're going to kick me. Good. And now pull back. Perfect. Okay. Making sure that each time that you're getting full strength out of your patient. If you're feeling like it's pretty weak, test it again. Encourage them to give you more muscle, because sometimes they're just either not understanding your instructions or they're not really giving their full effort. Let's see. Important also to make sure you test the big toe, because going back to the problem with back pain and the L5S1, disc compression is a common area that can occur. That's the weakest part of the back in the spine. So go ahead and bring your toe up against my thumb. Push up. There. Perfect. And that is the same innervation as the sensation on the lateral part of the little toe. So you want to make sure you test that out, especially in someone who has hip pain. Back pain. Okay, now if I could get you to lie down for me, I'll give you something to, we're just going to look at your abdomen again. All right, so abdominal reflexes, they're not present in everyone, so not having them is not necessarily an indication that there's a neurological deficit. You really have to put, just like every piece of the exam, you really put your data together with the rest of the picture. And so one finding that's abnormal does not necessarily indicate a problem, but it does mean that you do a little more testing. So the key here is that you briskly scratch, if that's a way to put it, towards the umbilicus in the upper quadrants and then away from the umbilicus in the lower quadrants. And the briskness is the key. There you go. Did that hurt?
No.
Okay. There, that's better. And we can do it a little bit. If you're having trouble feeling it, you can also put your finger right in the umbilicus and you may be able to feel that sensation. If I did it 2 or 3 times, it would probably fatigue that reflex. So then she would, and people can also, they can overcome it, especially if their muscles are tense or anything like that. So you may not always pick it up. With the meningeal irritation testing, the very first thing we're looking for is nuchal rigidity, which means that the neck is very stiff, and if you try to move it, your patient will resist that. They will not let you flex that neck forward. And then with the Brudzinski, again, they're trying to decrease pain, and so if you put a stretch on the meninges, the patient's going to try to decrease that stretch and have less pain. So by bringing her neck up, which I'm going to do here for you, and you want to bring it up, the patient, this is a passive maneuver, not an active, so you don't have your patient bring their head up, you do it for them. And what I'm looking for is to see if she, in response, bends her knees and tries to take some of the stretch off that back, because that hurts. or she may just not let me do it. And the same with the down here in the testing the Koenigs. You bend up the leg, and I'm going to go ahead and stretch your leg out and bring it up. And she is going to either resist me doing that, or this will cause increasing pain by putting, again, a stretch on the meninges. That's similar to something you'll learn in the MSK module for the straight leg reflex. The difference here is the reason you would do this is if something made you think that she had meningeal irritation. And so you're putting the results of your exam with the whole picture of the history and the rest of the exam. And that's the end of the 501 Special Techniques. I'm Phyllis Christensen, and today I'm going to do a brief demonstration of how you can do muscle strength testing and reflex testing on a patient who can't get out of bed. Most of the rest of the neurological exam that you need to do, you can do on pretty much similarly to how you would do it if they were sitting on a clinic table or able to stand up and walk around the room. Mary, thank you very much for being our patient today.
You're welcome.
All right, I'm going to go ahead and start by doing first muscle testing. And the upper extremities are pretty similar. So if I can get you to squeeze my fingers as hard as you can. Good, great. Now if you can make a motion like this with your arms, with your palms facing you. Don't let me pull you down. Good. Now push me away as hard as you can. Great, okay. Don't let me pull your arm. Good. Now push me away as hard as you can. That's great. All right, you can go ahead and relax. I'm going to come down here and test the strength in your legs. So first what I'd like you to do is to try to lift your whole leg right off the bed, and I'm going to resist you. Perfect. Okay, go ahead and relax. Now the other leg, lift your whole, perfect. Okay, I'm going to bend this leg up. And what I want you to do is try to take your lower leg and kick it up as if you're going to straighten it, and I'm going to resist you. So go ahead and try to straighten your whole leg out. Perfect. All right, good. Now what I want you to do is keep your heel on the bed and don't let me pull it up. All right? Good job. All right, great strength. You can relax now. All right, let's try this one. First thing I want you to do is to try to kick your lower leg up, and I'm going to resist you. Good job. Okay. Now what I want you to do is keep your heel on the bed. Don't let me lift it up. Good. All right, go ahead and relax. Perfect. Cover your back up a little, keep you warm. Can you bring your toes up towards your nose on both feet? Don't let me push it down. Good. All right. And now I'm going to come down here, and I want you to push as hard as you can. Push down. Good job. All right. Now we'll go ahead and check your reflexes. And I'll start with the brachioradialis. And again, the upper extremities aren't too much different than they would be with someone who's able to sit on the exam table. I saw your little thumb go, not a lot of big one, but... And if I can't get this one very well, I'll just go ahead and work on the biceps one. So I'm going to have you, and I'll go over and do it on the other side in a second. Good, okay. That was great. Now I'll go ahead and relax. I've got you. Good. Okay, I can't reach across very well, so I'll come over here on the other side and work on this one. We'll see if we can get this. A little bit, but not much. So I'm going to check your biceps. I'll pull your arm out a little bit here. Put my finger on your tendon. Good job. All right, now I'm going to let you just relax. I've got you. Now, for some reason, I'm not doing this one as well. There we go. Okay. let's do your legs. I'm going to lift your leg up for a minute. And then I'll hold it up. You can go ahead and relax. Good job. All right, and while I'm on this leg, I'm going to go ahead and have you kind of cross over the other leg. I'll take your foot and stretch it out a little bit here. There we go. Good. Okay, second leg. Lift you up like that, and you can go ahead and relax. Oops, there we go. That one works, huh? I'm going to bring this leg in, bend your leg again one more time. And let's see, go ahead and relax. There we go. I could feel that. All right. And that's pretty much it for strength testing and reflexes. The very last thing is I wanted to demonstrate how you would grade someone's muscle strength if it wasn't full strength or 5 out of 5. So we know that 0 is nothing, not even muscle movement. 1 is a flicker of muscle activity without being able to move the part of the body that we're asking you to move. And then 2 is if you're able to move it with gravity removed. So what I'm going to have you do is we'll take this arm and put it out here, and we're going to pretend that you're pretty weak and you're not able to lift this. So if I asked you to lift your arm up off the bed, you're not able to do that on that side. What I'm going to have you do is, from the elbow, can you bring your arm into your side, your hand over by your hip? Good. And now can you take it back out again? Perfect. We'll do the same thing with your wrist. Can you take your wrist away from you, your hand away from you, and then bring it towards you? Perfect. Okay. So that means your strength on that side is at least 2 out of 5. And if I asked you to turn over and you could bring it all the way up, then you'd be at least 3 out of 5. We can do the same thing on the legs, on the lower extremities. If you, for example, can you take this leg and move it away from you out across the bed? All right, and then are you able to bring it back in to meet the other leg again? Good. So if you can do that, but you couldn't lift it off the bed, that would be 2 out of 5. And that's it.